I'll welcome Dr. Chelsea Clinton. She's going to moderate the panel here and get all of you started. So let's give them a big round of applause as they come up.
Sorry for that awkward two-step. Really feels like, I don't know, who's on first or whatever the right health, not necessarily sports metaphor is. Thank you all for having us today. This feels like a particularly important conversation this week. And I'm so grateful to share the stage with three people that I admire and have had the joy of supporting in their respective journeys. I thought I would kind of start with asking each of them to kind of introduce themselves and kind of answer the central question of this panel, kind of how they're each kind of using both health equity to spur innovation and how they're using innovation to help spur health equity. And then ask a few follow-up questions and then open it up to the room. I have enough curiosity to certainly keep us going for 45 minutes, but hopefully you all will have questions for these extraordinary individuals. And Simmone, I'm going to start with you because you're closest to me. So maybe you can introduce yourself, kind of introduce Poppy, and then answer the question of kind of health equity into innovation and innovation into health equity.
Sure. Hi, everyone. My name is Simmone Taitt. I'm the founder and CEO of Poppy Seed Health, and we are in the maternal health care and reproductive health care space. And so as it relates to equity, especially for us, before I hired one person, before Chelsea and I ever met, I knew that equity was going to be at the foundation of what we do at Poppy Seed Health. So specifically, we connect people on demand, 90 seconds or less. We really say that for the press, it's more like 9.5 seconds, to a doula, nurse, or midwife somewhere in any of the states across the country. It is all text-based, and we focus on non-clinical emotional and mental health support. Which, by the way, is the number one reason in our country postpartum today for the cause of death. And most people don't know that the CDC also says that it's 100% preventable as the number one reason. So, I thought, why in the world are we not addressing the number one reason people are affected as they're going through transformative periods in their life, specifically maternal health care, which I think is demanding of innovation and a better way of doing things. So at Poppy, it doesn't matter who you are, where you live. We make sure that we're able to support you, and that is through a really bold stance in that we take whatever we're getting paid from our partners. We're able to also support people on Medicaid, which means 30% of everyone who are on Medicaid, underinsured, undocumented, are able to get that exact same on-demand support at Poppy Seed Health around the clock. And it also means that about a quarter of all of our conversations, if you can believe this, y'all, are coming from healthcare deserts. And we know that is a growing epidemic in healthcare. So I'll stop there. That's what we do.
Ellen?
Amazing. I'm always in awe of Simmone, who is both very articulate and solving a very important problem. So I'm Ellen DaSilva. I'm the founder and CEO of Summer Health. We do on-demand pediatric care. We offer care around the clock, 15 minutes or less. It is clinical in nature, so we can treat, diagnose, write a prescription for your child ages 0 to 18. We are clinically active in all 50 states, which is very important when we think about care deserts, social determinants of health. As Simmone was pointing out, 51% of children are born on Medicaid. That is 32 million kids in this country, and there are 75 million children under the age of 18. 33% of them don't have access to a primary pediatrician in their county, which means, and that number is going to get worse because the number of residents going into pediatrics, the number of providers, the number of residents going into pediatrics is precipitously declining, and the number of providers leaving pediatrics is accelerating at an alarming pace. That number's on track to be about 50% of kids living in a care desert by 2030. So at Summer Health, we are expediently leveraging technology to make sure that all children have access to the same kind of care. It's an issue that's near and dear to my heart. I have 3 young kids, and I can't imagine what it would be like for our most vulnerable population to not have great access to care. That's what we do.
Josh?
Josh, I'm the founder of Stepwell Care. We provide addiction treatment. Our model is a hybrid one. So we do both in-person and virtual across levels of acuity. So we provide all levels of outpatient care, from ambulatory detox, PHP, IOP, outpatient, medication-assisted treatment, and addiction doesn't discriminate at all. And so one of the goals behind the hybrid model is how do we allow people to engage in care no matter what their situation is? Do they need to come in person? Do they want that in-person kind of camaraderie and fellowship? Do they have a busy work schedule or family at home that they can't leave, or they don't have access to transportation, in which case they can engage virtually. If they have a crazy work schedule, we can kind of work around them, do weekend programming, that sort of thing. We also use technology in order to personalize care. And so what that means is we have care team personalized prompts that highlights different things. We do all sorts of different assessments that map to 50 different elements of what's called the recovery capital, which is essentially all of the resources, both externally and internally, that make up who somebody is. And so that covers the social determinants of health. It covers things from sleep health to access to culturally competent primary care provider, for example. Transportation, as mentioned before, to triggers and coping skills, things that are more kind of addiction specific. And then we use that to kind of personalize the care plan. So in addition to the work that they do with the clinicians, we use generative AI to create different pieces of content, whether it's video content that maps to something that they identified as wanting help with, or an activity that maps to one of those assessment answers or what they told their clinician. And so we kind of collaborate that way to continue to measure whether or not this is working, and is one of these areas a need for somebody that could lead to potentially a far worse event than, or rather state than where that person is in this moment.
Each of you touched on, social determinants of health. Certainly Simmone and Ellen, you mentioned Medicaid, and those are often kind of what we first think of when we kind of think about health equity. Importantly, we also know, though, that stigma is a part of kind of the ecosystem of challenges around whether someone has access to, timely, high quality, affordable, sustained healthcare, and how often kind of stigma can be a barrier. Josh, I wonder if you can talk about kind of how you really tried to help through personalization, through technology, through kind of the generative AI, facilitating the personalization, that you've really worked to tackle stigma and to help people feel kind of comfortable and affirmed in their bravery of stepping forward and saying, I know that I need care, and I'm likely going to continue to need care on my recovery journey.
Yeah, absolutely. So obviously the stigma is a big thing with receiving care. A lot of times it has to do with family members or spouses. And so we provide educational material to those individuals. We also offer sessions with them so that there's kind of some education that goes on around what is addiction. It's not the person's fault. It's not a moral failure of character. We also stress that this isn't a program where we are going to kick you out if you have a relapse or recurrence. We know that, especially in early recovery, the data shows that having a relapse or recurrence is not actually indicative of long-term outcomes. And so we try and keep people engaged in care that way. We also provide virtual care if people want. We'll only do that. And so that way they can engage in a private setting. Maybe they don't want to do group sessions. We'll still keep them in care, knowing that that's better than no care at all. And lastly, if they do engage in that care, we make sure that if we're sending things like tox screens or sending out for labs or medications, that all of the packaging does not say the company name or anything related to addiction or anything of that sort for that patient's privacy, because that is their business. And all we can do is kind of educate them and give them or empower them to educate those around them. We also use motivational interviewing. So sometimes people they don't want to be known as an alcoholic. They don't want to be the person that is sober at their wedding, or is kind of sober period, and people wonder what's going on with them. And so in that case, we have a program for people who want to practice moderation or harm reduction. And the goal there is, again, it's better than nothing at all. But at the same time, we use motivational interviewing techniques to try and get them to engage in further care if we deem it as necessary.
Ellen and Simmone, Josh spoke about the ways in which Stepwell kind of measures itself and how it's doing on its mission to help support everyone kind of in their recovery journey, kind of that's within their kind of patient population. I wonder if you each could talk about how you think about metrics, kind of what are the important kind of metrics for you, both for kind of the patients and the providers on your platform, but also kind of at a population level.
Sure. I'm happy to. So, from a metrics perspective, what's important to us at Summer Health is how many patients we can engage with in a month and how many times those patients come back to us continually. It's one thing to be able to help your child in that acute moment of need. And I can imagine that anybody who has kids in this audience has had that experience of, it's 9 o'clock on a Sunday night, my kid has a fever or a rash, what do I do? That's a critical moment where we can reach you. But actually the best moment is when you come back and you say, actually, thank you so much for helping with my child's rash. I'm also a little concerned about this developmental issue. I'm also concerned about their social behavior or something of that nature. And then we can build that real relationship with you, that long-lasting and longitudinal relationship. So that second touch point is actually much more important to us in measuring what percentage. Right now, about 72% of our families have more than one touch point, which means we can foster a real relationship with thousands of families around the country. And that's critical. The other metric that's very important to us that helps foster that magic moment is response time. I'm blown away. I'm really keen to hear about Poppy Seed Health's response time. We pride ourselves on getting you to a pediatrician who's an MD in 15 minutes or less. Our average response time is 2.8 minutes. And again, that magic moment of a pediatrician enters the chat immediately and can help solve your problem or write a prescription. If you can do that in 2.8 minutes, that's a very defining moment for a parent in their health journey.
Simmone?
So there are two ways that we measure. We don't like calling it success, but we like to measure it in support. And that's both with our member, so the person seeking support, and also our advocates. I just have to pause to talk about our advocates because this is the infrastructure that already exists in healthcare. We already have nurses, we already have doulas, we already have midwives, but we're just not leveraging them in the intersectionality of all that they do. So part of the metric that we really focus on is that response time. Why is that so important to us? It's important to us because not only does that member need the support instantaneously in really acute moments, but our advocates who are working around the clock across, wherever they are, can be, sitting on the couch in their home in Kansas, but supporting someone here in New York City. And so that model for us and that measure of how quickly they're able to connect is very, very important, especially in the acute moments. And the measure of how quickly we're able to respond to them is also directly correlated to how long they stay in the chat. So we are text-based only. I promise. We have tried video. No one wants to talk about their third trimester hemorrhoids on video. Okay, it's not happening. We've tried phone calls. No one wants to show up to talk to someone they've never met on the phone. It's awkward. But everyone will pick up the phone. And the majority of people, regardless of socioeconomic background, have access to a phone, maybe not broadband, but to a phone. And so what we found is that on average, our text conversations, to just think about your own behavior, they're 37 minutes long. And that's just for someone who has found Poppy Seed Health, downloaded the app, and they come and chat with us as soon as they hit that button. Now, with our enterprise customers, a lot of the folks in this room, you fall into that category, I believe. Those conversations are on average 51 minutes long. There is not a doctor, although they really want to, in your appointment. There is not a way that providers are able to burden, on average, on a monthly basis, about 7 to 8 hours of support time out of office. And so we're just leveraging the infrastructure that already exists. But those two metrics are really important to us: how quickly we're able to support someone, that connection with our technology. And then the second thing is how long they're staying in that conversation.
So important. Josh spoke about the ways in which, Stepwell is leveraging generative AI. And I wonder, Ellen, if you could talk about kind of the ways in which Summer is leveraging generative AI. And then if, after Ellen, you share what I know you're up to at Summer, kind of each of you could prognosticate about kind of where you think over the next 12 months generative AI could impact your missions, particularly as it relates to equity. But Ellen, why don't you share what you're up to, and then we can go down the line.
Yeah, I think it's great to have this conversation in the halls of Microsoft, which has been on the front lines of investing in generative AI long before any of us ever had touched our hands on ChatGPT and the like. So this is certainly very topical and relevant to where we are now. But when I think about generative AI, in this room, we've got a lot of digitally native individuals who are very comfortable and facile with using these tools. The populations of individuals we serve, especially we focus on the Medicaid population, don't necessarily spend a lot of their time. And I don't want to make broad generalizations. I think AI is making material changes on the consumer front in general, but we are not necessarily assuming that our users on the front end, our caregivers, are AI native. And so the way we embrace AI and generative tools is on the provider side. We have built our own electronic health records platform that is completely AI native, and we're actually a partner of OpenAI's. We were the first company to sign a BAA with them and work with them starting in 2022 to build an entirely AI native suite of tools for our providers. What that means is the minute a visit is closed, and by the way, I should have mentioned this, we're also all text message based. So everything is written, which makes it very easy to actually use that data, leverage insights from it, and automate certain things. We have tools that automate SOAP notes, so the providers don't have to do any administrative work. We have tools that help auto-generate and autofill what the next message could be from the provider. So the experience feels very magical for the consumer, but they are talking to a real person, and they are not necessarily assuming that they are interfacing with any form of AI. But our providers who are human are getting to leverage that technology to create a magical experience.
I wonder now, maybe Josh, where do you think kind of AI could influence, impact, enhance, whatever the relevant words are, what you're kind of doing at Stepwell and kind of addiction, treatment and therapy kind of more broadly? And then maybe Simmone, the same question, to you for pre and postnatal care, but Josh.
Yeah, absolutely. I think a big part of large language models is the ability to communicate with, it's a computer, but has the feelings of something that speaks and acts like a human. I think where you get into trouble is it is not 100% accurate. And when you're talking about doing it in a clinical setting, it'll say things that they're very confident in. It sounds like it's true, but may not necessarily be. And so for addiction in particular, I think where it's most helpful is in the off hours. A lot of times people get the biggest cravings, or they're feeling really lonely or down in early recovery. And it's 3 a.m. on a Saturday. Getting access to somebody to speak to at that point can be really difficult. And so being able to offer that to somebody with the understanding that you are speaking to AI. Maybe it's trained on specific data, but it says AI, we're not trying to trick you, because I do think that is a big issue when it comes to mental health and AI, is if you're speaking to a computer, even if it's the exact same therapy you would be getting from an individual, it doesn't feel the same. That client to individual relation or provider relationship is really important, the therapeutic alliance. And so that's one way. Another way I think is when it comes to like CBT, so helping people to reframe thoughts. You can train that on all sorts of data that exists already. And again, that can happen in off hours that are not in a clinical setting.
Simmone?
Oh man, I might get kicked out of the conference after saying this about AI, but um, it lacks empathy. And at Poppy Seed Health, we're in the business of empathy at scale. Now, it will get better. That is the most beautiful thing about innovation. But I also know that 56% of our advocate network identify as somewhere on from being Black to Indigenous. We 30% of our advocate network are queer, right? It reflects exactly the people that we support every single day. And so the way that we've thought about AI at Poppy is not to make it consumer facing or patient facing just yet. What we're experimenting with, and we're really excited actually about this year and how much we're thinking about scaling this beyond our beta group, is how AI can improve supporting our advocates in their own mental health journey. Because let's just remember that those nurses are proud to be nurses, but they're burnt out at a level that we've never seen before. We know more and more providers are leaving the workforce, not just because of burnout, but also because of disappointment, and also because they have no safe place to go to have a conversation about their feelings and their own mental health. So the way that we're using AI today is just not at scale at Poppy, and I have to admit that. But the places that will scale for us are going to be internally first to support the humans that are supporting the other humans by doing empathy at scale.
Ellen?
I wanted to add that something that we haven't necessarily talked about, but probably the area I'm most optimistic about right now in AI and healthcare is actually around digital diagnostic tools. We've started seeing more of these in the market, but imagine you could take a photo of the back of your throat and get a strep throat diagnosis, or of your inner ear and get an ear infection diagnosis. That is at our fingertips, and that is very valuable and very useful to keep people out of emergency room and urgent care and other high frequent use settings. And while I agree with you on the empathy front, I'm excited about some of the applications that maybe don't require empathy, but can actually solve real problems in the short term.
I want to open it up to the floor for questions, but before I do that, I just want to ask each of you, you know, how concerned or excited are you about all of the changes that could be coming, that are coming, given the new administration? And you can be both concerned and excited, or just one or the other. Ellen, you're nodding, so I'm going to start with you, and then maybe Josh.
Go last, because I just spoke. I would say on balance, I'm pretty concerned. I have an eye toward Medicaid budget cuts, which I think are coming and I think are going to affect a lot more people than we realize. I am optimistic at the level of investment that we're making in technology, and perhaps those two things will counterbalance one another. But I would say my focus right now is on making sure that the underserved populations who are supported by government-sponsored health insurance, that doesn't go away entirely. And so I am watching that very closely.
Josh?
Yeah, I think that's a good point. We already come up against closed networks in Medicaid, and a lot of individuals that come to us who have Medicaid coverage tell us that they can't get into the folks that are actually in network, and so coverage already is not sufficient in most areas, and so restrictions to that be really devastating. Addiction population, I think that's one part of it. The other part of it is as it relates to new pharmaceuticals or interventions. I know the incoming head of HHS has already talked about against GLP-1s, and there are some promising initial research findings around the efficacy for addiction. And so that is something that I have paid close attention to, because the initial findings are really exciting, but could all be brought to a halt, and we may not know for 4 or 5 years if that's the case. With that said, there are other incoming folks who have expressed the opposite feelings on GLP-1. So that's just kind of one example around approving new medications, which for addiction especially, buprenorphine has been life-changing for people with opioid use disorder, but the same thing doesn't exist for stimulant use disorder and other substance uses as well.
Simone?
I'm thinking a lot about what Josh is saying as well, because I, mentioned mental health related conditions, but number two, about 20%, by the way, is substance abuse related conditions and postpartum and pregnancy and prenatal care. So of course, I am extraordinarily concerned about what is happening. Frankly, more about the misinformation and what is being said now and what will be said in the future of just things on a whim, right? So drink bleach, you'll be okay, right? Like things like that, that is pretty critical to people's health, period. I'm calling it misinformation. I really want to say lies, and things that aren't founded in fact and in health and in experts that I'm very afraid will not be a part of the committees and cabinets. That's my real take. That's my hot take. But I will add one other thing, which is really important. A part of our safety net communities around the country are in many ways invisible to begin with. So when we have abortion bans and restrictions to healthcare that is life-saving. I'm a woman that's had multiple pregnancy losses. I just happened to be in New York City, so I was able to get the care that I needed. But we know, and there are already deaths that have happened because of some of these bans. Those invisible communities are going to go even deeper into places that we absolutely will not be able to find and help them. And talk about stigma and shame. This is the person who already, if you do not have health insurance in our country and you're pregnant on average, you're showing up at somewhere between 20 to 24 weeks pregnant with no prenatal care, no support, and you're showing up when it's ready to have the baby. And we know that we can lower comorbidities, we can lower a lot of really adverse things to someone's health and that child's health by supporting them. And so I'm very, very concerned, but I'm not scared.
Questions? I guess we'll start over there with the man with the red hair. Yep. Sorry, I don't know if I don't know your names. I'm going to have to identify you by your hair color or time. I apologize.
Been the redheaded guy in the room my whole life. So Rory Burrell from Wobot Health. First off, Simone, what you say about stigma and the text-based approach, amen to that. I couldn't agree anymore. I think this is really a question maybe for Ellen and the rest of the group. That second visit is so critical, but like the most expensive visit is that first visit. It's expensive in terms of the providers. It's expensive in terms of the time. How are you using technology to get to that second visit and a third visit and beyond?
Nice to meet you. All three of my kids have red hair, so I empathize with what you're going through. So the question was, how do we think about using the most expensive visit? We talked about the importance of the second visit, but the most expensive visit is the first one. And how do we leverage technology to really make it either memorable or draw them in? So at Summer Health, we use pretty traditional direct-to-consumer customer acquisition channels to acquire our customers, even though some of them are covered by their Medicaid plan in full. And that comes from my background. I was the 8th employee at Hims and Hers and helped grow that business to its public state today. In doing so, it means that there's a lot of agency that the individual has selected to use our service. And we try to do a lot of education within that first visit on, again, it's all via text. So how we work, what kinds of questions you can ask. We do a lot of education on introducing you to the provider. We send you a link to their profile. They do either an asynchronous video or some kind of text-based introduction of themselves so you know who they are. We have a trope at Summer Health Club being default helpful, and we really try to get you an answer to your question in that first visit. The last thing we do that I think is absolutely critical is 100% of your first visits get a follow-up within 24 hours. So if you come in and you've got a question for us, within 24 hours, the same provider is coming back and saying, did we answer your question? Has the fever gone down? Is the rash better? Is everything okay at home? And that really endears individuals to feel comfortable coming back to us. And I think that follow-up is very key to what we do. And a lot of that follow-up, the initial message is automated. So it doesn't necessarily require an individual unless the person responds.
I'm just going to go around the room. I saw the woman with yes in black next.
My name. So Lena Clean, I'm a national advocate for patients, and I have an FQHC background. I had a quick point of information for Simmone. I'll be happy to share this with you after the meeting, but there was a JAMA internal medicine study of chatbot responses against physician responses on text. You know the study? So it showed that they were like 10 times more empathetic and preferred 80% of the time by patients for the quality of the responses. It was a small study. I just find it interesting. I think it's not empathy you're concerned about as much as it's accuracy, follow-up, and the kind of intelligence you need from a psychiatrist or a nurse that you're not going to get from a chatbot. But Ellen, I did have a question for you.
Sure.
So just to put this into context, I got involved in diagnostic quality and safety and patient safety because my own son nearly died at 15 after having been misdiagnosed at least 20 times in his first 15 years of life. So this is the work I've been doing with Kristen and a lot of other people in healthcare. We know that children are misdiagnosed at a rate of 4 to 7 million kids a year in this country, and it impacts them far more than it does adults. Adults are 1/3 are grossly impacted, but for children, it's much higher because they have developing bodies. It affects their attitude towards themselves and medicine, and we could go on about this forever. Are you able to measure the diagnostic quality of what's happening in these interactions where they're not able to actually touch the child or speak to them alone?
Yeah. So the question, I didn't mean to. Thank you for your question. The question was, are we able to measure clinical accuracy doing things digitally based on the number of misdiagnoses that children tend to have, which disproportionately affects kids? The reason, so I've seen a bunch of studies, mostly from the Journal of American Medical Association, that I know what you're referring to, that are both disproportionately misdiagnosing and also overprescribing of antibiotics for kids and the like. A lot of that comes from the fact that we have non-pediatric trained clinical professionals treating kids in circumstances. If you go to an urgent care with your child, you're probably not getting treated by a pediatrician, which means they're using their best judgment. But what is true for kids are not many adults. And so what is true for children is not necessarily true for adults, which is why these misdiagnoses tend to happen. I don't want to adjudicate on the issue of your child, and I'm sorry, but it sounds like maybe things are better.
Adult now, nutrition.
Oh, good. Okay. But something, so a few ways we mitigate that. The short answer is yes, we do measure clinical accuracy. A lot of that comes from the follow-up that we do. We make sure we try to catch things. We try to close the loop with your existing primary pediatrician if we can. A lot of this stems from the fact that we are staffed exclusively by pediatricians who are MDs. We don't have other types of clinicians on the platform, whether it be other licensure or other kinds of practitioners. And it's very important to us that our clinical accuracy is extremely high. We tout that, we talk about that with plans. And we do measure health outcomes of our kids, and we're very proud of that.
There's another question here, sir.
I wanted to follow up on kind of the last point, kind of this current administration, some of the concerns that you brought up, so the platforms and providers that are operating across the country. You're starting to cases come up like there's a doctor you prescribed pills to Texas, and Texas is trying to sue that provider. So I was wondering how you think about that from as you probably have providers that are practicing across state lines or share. How do you think about protecting providers on the cloud?
I want Simmone to answer. this
Yeah,
one,
well, you should definitely answer from the MD perspective, but so the one of the most innovative things that we did at Poppy in terms of the structure is that um, think about Poppy as like Uber and DoorDash smashed together, right? So all of our advocates are 1099s, but they're full-time nurses doing what they're doing in their state, wherever they are. And so it was really important for us when Texas specifically, so I like that you brought up Texas, passed the SB8. Right. And we knew that we had a fiduciary responsibility to protect both the patient and that nurse or, that advocate. And so what we did, and I'm really giving away the secret sauce here, but what we did was we used our algorithm, that algorithm that takes about 300 milliseconds to connect our advocate and our member, which is why it's so quick. And we said, well, wait a minute, we know and we can identify exactly where these people are. So how about if we just don't connect them? It's very rare that an advocate in Texas and a member in Texas would be connected because that's just not how our algorithms work. But in the case that it did, let's try it out. And so we were able to basically block right connections. And what we called it internally was safe haven states. And so we also knew that these laws were very gray. And so we would have to look at where some of these bans and SB8 laws might be. And when we looked at it collectively, we were like, oh, we can do this fairly easily. There was only one place that we really wanted to go with that, and that was to our enterprise customers, because we also knew from a legal standpoint that they also had the same concerns that we did. That's exactly what we did. That was about 2 years ago, and it completely transformed our business. And that is how we protect both our patient and also our providers, in that they're able to give the kind of support and also, by the way, receive the information. Although we're doing non-clinical support today, they can receive the information in a chat. If a member says, by the way, I need to leave Texas and go to, Mississippi to get a DNC because I can't get one here because of medical reasons, whatever it is, right? No one is going to get, let's say, in trouble for that, right? Especially because of the safe haven. And so anyway, it's called something else externally now, but that's how we've been able to protect. And it's also how we've been able to really scale with our partners.
Ellen, did you have something to add?
I will be brief because I want to make sure we have enough time for everybody to answer, to ask questions. So we do have 50 medical practices across the country. There are about 40-ish 50 state licensed pediatricians in the country. 35 of them are exclusive to Summer Health. So we've basically created a network of 50 state licensed physicians, which means our physicians can practice across the country. We've built technology that will sort of like auto route patients to providers who are licensed in their state. And then also embedded in the technology that we've built, we have guardrails around what you can prescribe in what states, so that the tech actually will block you from doing something that you can't do, which I think is better than the providers being on the hook for needing to know the rules.
Josh, do you have anything you want to add?
It's not something that we faced.
Okay. Any question? Yes.
I'm with Northwell Health. I'm a nurse by background. We're using chatbots for moms, pregnancy education, and then postpartum follow-up. And I just want to touch back on the texting piece you're talking about. Anecdotally, some may have heard this story from me before, I'm sorry. We had one mom, a healthy pregnancy, delivered, went in for her first postpartum visit, and had a great visit. Pictures of the baby, everybody's excited, congratulations. And went home and got the chat that happened to have a depression screening and indicated suicidality. She was having suicidal thoughts. And when she answered the questions in the chat, a nurse pinged immediately and called her, and we got her the services she needed. And the lesson to me was, I do a lot of work with chatbots. We think that this is cold or impersonal, but there are use cases where it's actually better, because when they asked this mother, why didn't you say something, or they didn't challenge her, but they were trying to understand what happened. She said, I was embarrassed in front of the doctor. The nurses were so excited about the baby, and I know it's a blessing. But with the chat, she felt safe to revealed what was really happening. So don't discount the texting.
Oh, no, definitely not. Yeah.
For some populations, it really works better.
Yeah. So thank you so much for that story. And it's an important one. And I hope that you all heard that. So one of the big things that we identified early on, we call it expert anonymity, right? You will, and this is proven, right? In therapy and psychology, you will tell someone one of your deepest, darkest secrets at sitting next to a stranger at a bar than you will your mom, your aunt, your best friend, whatever that looks like. And I know that. I should have also mentioned that I left my, big, tech executive job and became a doula full time because doula saved my life. And I didn't really understand how incredibly important that was. And so boots on the ground a full year before I even started Poppy Seed Health. And I was pressure testing this. Do you really care about who you get, how often you get it? Do you really care about the driver who's driving you in that Uber? Do you care about the safety, getting to where you need to get to, and all of those things? And so it applies very much here. And so I guess I should say very blatantly, we're not against the chat bots. We just need them to get better over time, which is why innovation is so important. But I'm not surprised because we also know that more than about 50% of folks that have that one survey right after you have the baby in the hospital, they check all the boxes of being healthy and fine in their mental health and they go home, and that is actually not the truth. But they're also not necessarily telling their partner or their doctor. And so at Poppy, anyway, you get a different person every time. People love that. We thought that they wouldn't, but they do love it. And it's because they can show up how they are. They're not there to talk about the weather, right? They're actually there to tell you the thing that's happening. Then they can close that chat and feel no judgment about it. But yeah, facilitating, I think, something like that, which is the after visit, is very, very important for people to get. And at scale, of course, a chatbot, works. And we're working very closely with Joe Kalman right now at Northwell to figure things out.
I'm so sorry. I just realized we're out of time. And I didn't even get to like this quadrant of the room. So if we're lucky enough to be invited back next year, I guess I'll start on stage left and move right, but then that requires everyone to sit in exactly the same seats. But really just so grateful to Health Impact for kind of sharing this stage with all of us. Incredibly proud to support these three kind of tireless innovators for equity and beyond, and hope that if you did have questions that you didn't get the chance to ask today, that you'll find each of them either later today or subsequently. And I don't really know if you applaud here, but I'm going to ask you to applaud for them because they're great. Thank you so much.